Okay, welcome in everyone. While we let everyone start to trickle in on their lunch break, welcome back to our Harborview Ethics Forum. We have Dr. Scott back with us today, speaking about applying a Black feminist, can't pronounce this word, epistemology to
Epistemology, absolutely.
perinatal
Mhm.
quality evaluation. I do not work in healthcare, so bear with me as I say these words. Um, just so you know, we will be recording today. But we will have this recording on our website and we'll send out that link as soon as it's ready. Our objectives for today are to name at least two Black women defined theoretical frameworks to contextualize the manufactured Black maternal health crisis, analyze a Black birth narrative through application of the PHI approach and Black feminist perspectives, identify at least one solution across three levels: structural, disciplinary, institutional, to shift power and shape safety during hospital births. So we have no financial disclosures to disclose today from the speakers or the planners. And if you are a UW learner, go ahead and text the code 16613 to the number on the screen. I'll also pop this into the chat, so if you don't catch it right away, it'll be there sporadically throughout the presentation. If you are not a UW learner, there's going to be an evaluation survey for you to take after this. And then at the end of the series, we'll send out instructions on how to claim credits for each session that you've attended. Our advanced training in healthcare ethics course, applications for the following course starting spring quarter are due on the 15th of next month. If you are interested in healthcare ethics, want to learn more about ethics consultation, or interested in becoming a healthcare ethics consultant, this is a great certificate program. It's completely online, distance learning. Go ahead and email us for any questions. And just a quick save the date, our annual summer seminar in healthcare ethics is happening the first week of August. Registration is going to open sometime this week. More details to come. Just be sure to mark your calendars for this amazing conference. So, without further ado, I have Gina to introduce our speaker.
Hi, everybody. I'm glad to see everyone here today and so many familiar names in the participant list. I'm Gina Campilia. I'm an associate professor in the Department of Bioethics and Humanities, and I do ethics consultation primarily at Harborview. I am so honored today to introduce, and I will actually keep this brief since this is the second presentation, and I really would love for Scotty to dive right in. I'm so excited for this talk today. Dr. Karen Scott is a chief Black feminist physician scientist, founding CEO, and owner of Birthing Cultural Rigor. And I am really so honored to introduce Dr. Scott today, and because the work that we saw at the last ethics forum was around differences between standard definitions of safety and the experiences of Black mothers around safety, and how those two things come apart, and how do we start to think about emotional safety as patient safety, especially in this context. How do we recognize and address the multiple forms of safety that Dr. Scott is introducing to us throughout these presentations. Dr. Scott has also been more recently integrating some of this work at University of Washington, which makes me extra excited to have Scotty with us today to think through some of the Black feminist approaches to this work. How do we categorize? How do we understand? And how do we do differently here? So I'm really excited for this presentation today to carry us forward from where we left off about a month ago, and I start to hopefully implement some of the things we learn here today from you into our work every day. So thanks so much, Dr. Scott, and I'll let you take it away.
Thank you, you all. Thank you, Gina, Jill, and Carrie. I'm going to start sharing my slides because we have this is theory day from our last time, and I'm also going to support you all to apply the theory. So I'm hoping you can see this. And hopefully the screen will change into presentation mode. I'm hoping, there we go. Okay, so thank you all for joining. If you are new today, thank you for returning. Again, thank you, Jill, Gina, and Carrie. So I'm going to dive in because we have a lot to cover, and I want to leave time for you to practice like we did before, and this time adding on what we learned today and then leaving time for discussion. So again, thank you for joining. So disclosure, I am employed officially at UW, but not to do this work. I am a research consultant at Dr. Kimido's lab doing nothing around this particular work. I am so grateful to be in her lab and working with them, but I am not doing this particular work. So I just want to let you know. So again, for today, it's a two-part discussion. What we're going to be doing today is how can we advance your knowledge and skills to embody a different critical ethical consciousness around the way we provide care, around the way we provide maternal perinatal care, how we train folks, and how we evaluate hospital-based obstetrics care. And again, this approach that I use is specific to Black mothers and birthing people, but you too could apply on more culturally responsive and rigorous and relevant frameworks and praxis to the populations that you're serving. Just know my exemplars today are grounded in making sure that we affirm, activate, and amplify the power and potential of Black women and people, and reframing the way we approach Black reproducing bodies and births, and not as pathology. Again, applying a Black feminist epistemology to perinatal quality evaluation, all the things I just stated, and hoping that you'll be able to better engage this work with the things that you learned today and also what we learned before. And no, this is just like a popcorn. You definitely need to read and study, but this is introducing you to this work with examples, and you'll have access to the slides. So the objectives are already shared, so I'll keep going so we can get to this work. So to add to the wonderful introductions that have been given to me by Gina today and Jill before, I am a Midwesternized Southern Black woman from East Nashville before gentrification. I do value the gift of a liberal arts education from the fifth grade all the way to completing medical school. I do believe in this being the way of a lifelong learner. I am proud to be all the things that are highlighted on there, especially a Care Bear hugger and Wakanda healer, as well as a health systems disruptor and transformer architect. I think I have yogi. I'm a yogi, Yoda, and Grogu follower, if you know those things, and a Trekkie. I'm celebrating 23 and a half years of being a community-based trained and serving OBGYN. And as you will see, I love teaching and talking about this work and building your capacity to adopt cultural rigor through the simultaneous operationalization of Black feminism, reproductive justice, and research justice in participatory quality improvement and implementation science practice and research, as well as interprofessional education and training. So like before, open a new window, pull out your smart device, go to www.menti.com and enter this code. You'll also see this will be always at the top of every single slide. So don't fret or get nervous if you miss this introduction or this slide. It will also be in the chat box, but just always look to the top of the slide for the same information. So like we did before, let's get kind of acclimated to this work. I know there are about 30 plus people online. I can see who's already engaging this anonymous real-time polling platform. There are about 14 of you all that are, as the numbers increase. So as we get about halfway through, like a little bit over 20 people, I will go to the next slide. So the first activity, briefly share, this response to this question. I woke up today feeling grateful for. You can actually put whole phrases, incomplete phrases. I woke up today just feeling grateful for this opportunity and privilege to share this work. I am a tad bit nervous. So I have a little script because I really want to get through these theories in a short but meaningful way so that you can see how adding these theories to your work can make for a more precise and accurate understanding and hopefully response to this manufactured Black maternal health crisis. And as you can see, when you respond, you will see in real time everybody's responses anonymously. I can move the screen up to show everybody's response. So yes, I say congratulations to the Seahawks. That's why I'm rocking this work, these colors. But yeah, it's just wanting to make space for gratitude because we'll be a little bit heavy for the work today. So, what is your primary role in your daily work? You can now vote. Again, as you respond, your responses will show up. They're color coded in percentages. Um, and I think I just changed out researcher for faculty the last time. But if your role is not listed, please write that in the chat box because we want to make sure we make space for all different types of folks who are joining us today. And hopefully, when you start responding, you will be able to see why, being inclusive and having representation and valuing people's contributions is so much more meaningful and powerful to the work. So just an open-ended question. What theories do you currently use to inform your problem analysis or to um, design solutions in any theory? You can also respond, I don't have one. I don't know what you're talking about. But if you do have some theories that are kind of your favorite ones to use, please just go ahead and type in what ones do you use. You will know my favorite theories after today's session that I pretty much use throughout my work. Thank you so very much, first responder, feminist. We see reproductive justice. You can also say, I don't know. I hope to gain a theory today. But what type of either belief system or assumption or truth do you consciously know that you apply to how you approach a problem or the solution? Again, thank you for responding. Autonomy, beneficence, I don't know exactly. Everyone has their own individual experiences and perceptions. Common sense, absolutely. I'm not sure, hoping to learn more. Holistic and spiritual, authenticity, integrity. Thank you for listing all of these: critical theory, Black feminist theory, disability theory, care ethics, authoritative knowledge, trauma awareness. Thank you, everyone, so very much. As you can see, just in this representation of the 26 people who are actively engaging the conversation, we see a whole list of theories that people are using. Let's keep going. And you still can participate even when today's session ends. This will be open for the next, I think, 48 hours. So please continue to come back as often as you like to add to the conversation. So first question, what is your experience in applying Black feminism in your work? You have 4 responses. They're organized by never, no prior experience because your experience is valid. But we also just want to know where you are. Never, no prior experience, all the way to current experience with evidence of use. And I am known either locally, regionally, nationally, internationally as a model for others. And then in between, you have a desire, right? An interest to learn to you're currently experiencing this or applying this theory with evidence of use. So right now, thank you for everyone responding. And the majority of people, in terms of just numbers, we see are around the yellow. They have an expressed desire, interest to learn. So we're going to go through the next theories that I'm going to introduce in a popcorn style today, just to see where you are. The next question. What is your experience in applying Sojourner syndrome in your work? Again, never, no prior experience, all the way to current experience with evidence of use and known as a model for others. And it's okay to put never. This also allows me to know where this current community of people, where your level of readiness is to engage today's conversation and beyond. We'll keep going and you can keep responding. What is your prior experience in applying reproductive and perinatal apartheid in your work? Again, you can either say never or you can move yourself to the yellow. You may not have heard it, but are you interested in learning? Do you have a desire to learn? Do you have current experience with this evidence of use? Are you known as a model to others? Again, thank you for continuing to respond. We're going to keep going and I'm checking the time. Okay. What is your prior experience in applying misogynoir in your work? Where do you fit along this kind of spectrum of experience and expertise? And again, thank you for responding and for participating. And as you can see, we have sometimes people in the yellow and the blue, no prior experience and interest to learn, or sometimes we have them in the different shades of pink, where we're rarely seeing folks in the current experience with evidence of use and known as a model to others, which means we have opportunities to grow. So thank you. Two more. What is your prior experience in applying obstetric racism in your work? No prior experience, never. You have an expressed desire, interest to learn. You have current experience with evidence of use. Or do you have current experience with evidence of use and you're known as a model for others? And again, I have no expectation today other than to share this work with you to see how you can engage it and apply it like in real time in this hour, which is a big ask, but I believe in you and I think you'll be able to do some of this work. So remember to just catch on to at least one of these theories today and consider how that theory is being operationalized or manifesting or being embodied in the experience of the patient, the hospital response, and the hospital's impact on the patient. So excuse the typo, but what is your prior experience in applying sacred birth in your work? Never, no prior experience, expressed desire, interest to learn. Now, I don't anticipate a lot of the pinks. I wrote this, I developed this framework. The book came out in December 2024. So I'm expecting more folks to be in the yellow and blue, but this again is an opportunity to share these things with you all. Okay, so thank you for participating. So buckle up, hold on tight. We're going to go through these theories in a popcorn style. So I'm being honest and transparent. It's just enough to get you through this hour so that we can see how utilizing these theories when interpreting a narrative for a Black mother's birth, how that can provide more accurate and precise understanding or interpretation, and hopefully a better response to the harm. So let's start here. I'm just checking my time. Okay, great. So in holding a necessary and transparency, I do have a script today because I want to stay on time. I love these theories, but I can get caught up. So here we go. In holding a necessary yet temporary space for the harm because change is happening, I share the following quote. Being born and giving birth are important moments of our liberation. In a Western society that does not yet respect and honor the full brilliance, self-determination, and spiritual power of Black women, the oppressive tendencies of the medical industrial complex violate the sacredness of birth. This is from Pauline and Mackenzie Day and Alexis Pauline Gums and mother-daughter doula team. And it's taken from the book Birthing Justice, Black Women, Pregnancy and Childbirth, edited by Julia Chinyere Opara and Alicia D. Bonaparte. Despite state and national quality improvement initiatives, clinical safety bundles, technological advances, and social protections, as well as safe motherhood initiatives, hospitals do not keep Black women and people safe. Hospitals willfully watch the death or near-death gap persist or widen between Black mothers and birthing people and other racial and ethnic groups in different hospital settings and across different perinatal conditions, experiences, and outcomes. And we went over a little bit of this last month. So one day in the past, I listened to this narrative and I was moved to tears as a Black mother performs what Dr. Donahue Davis names as racial reconnaissance, one of the dimensions of obstetric racism, as defined first by Dr. Donahue Davis, which I'll define later. For now, I invite you to listen and read the story as a Black mother who is also a Black woman pediatrician describes the Herculean efforts made by Black women to avoid or mitigate racist encounters, including being hypervigilant about procedures and finding providers. Thank you for this meaningful study. Although I was stressed out due to delivering at the peak of COVID-19 in New York, I strongly believe that my experiences were better than most other Black women delivering at the same time, simply due to my profession as a pediatrician. I was able to call in many of my friends who were Black OBGYNs working in the hospital to oversee my care, and they helped me tremendously. It is very unfortunate that my connections and profession afforded me with these opportunities, despite the fact that overall it was quite traumatic due to the pandemic. I pray that the system changes for the better to accommodate all Black birthing bodies so everyone receives similar special care and attention regardless of their career paths and internal connections. And I do just want to take a minute to pause to honor mothers who were taken from us prematurely who had a plethora of advanced degrees. Dr. Shalom Irving, who was at the CDC doing this work and studying this. Doctor, and I'm blanking on her name. Please forgive me. She was a chief resident, I think, of pediatrics at a hospital at Indiana University, who her hospital, as the chief pediatric resident, failed her. And then most recently, Dr. Janelle Smith, who was a doctoral trained nurse practitioner and a certified nurse midwife, who also actually supported, I think, almost 6 births or so during the last 24 hours before her life was snatched away from us. So in this example, just letting you know that even when you are working in the system as a doctoral trained provider, you are not safe. We are not safe. So again, listen and read these powerful words from doula Gina Maricela and Rodriguez, a doula from Birthing Justice, to get a sense of birthing as a Black, Indigenous woman or person of color in U.S. hospitals. I came to understand the hospital as a place that continues a colonization of our bodies, our wombs, our first breaths. Colonization is defined as the action of appropriating a place or domain for one's own use. Appropriating is the action of taking something for one's own use, typically without the owner's permission. In this quote, I'm reminded of the brilliance of historian Dr. Deidre Cooper Owens from her book, Medical Bondage, in which she stated, the men who practiced antebellum era medicine needed bodies to advance the field and to recognize formal medicine as legitimate. We're talking about 19th century. The ready availability of sick Black female bodies did more than aid pioneering gynecologic surgeons as they cured formerly incurable diseases. In order to decolonize birth, I realized I needed to describe the birthing experiences through the perspectives of the communities carrying the greatest burden of deaths and near deaths, as well as the higher power and potential to offer solutions, particularly since the mothers of gynecology originate within and across generations of Black enslaved women in the role of surgical teachers, nurses, leaders, and patients. So, to move towards a future of Black sovereignty during childbirth hospitalization, let's confront our past briefly. I would like to situate the medical industrial complex and quality improvement leadership, ethics, knowledge, and practices within the historical context of legalized sexual and reproductive oppression, exploitation, extraction, and experimentation of enslaved, diseased, and/or dead Black women, girls, and gender-expansive people across 5 centuries, starting with the 17th century. The next 2 slides represent big picture generalizations of legalized events and their historical impacts with contemporary implications for how science, medicine, and quality view and treat, or rather dismiss and mistreat Black women, girls, and gender-expansive people. So in 1662, we wonder why even now, present day, the race of the mother, right, determines the race of the child. Colonial Virginia legislators made Black women's childbearing a centerpiece of the system of chattel slavery when they passed a law stating that the status of the child would follow that of their mother. The principle legalized chattel slavery as an inheritable status applied to Africans and their descendants. 18th century, white physicians and slave societies acquired professional success and credibility by medicalizing Blackness in their professional writings and presentations. The racialization, medicalization, and commercialization of Blackness, Black bodies, and Black births extended pro-slavery practitioners and became part of the language of the broader profession. So in this slide, it displays an analysis of relationships between slave and plantation owners and OBGYN physicians and the roles they played individually and collectively in creating, sustaining, and expanding the slave economy and labor force. This analysis characterizes their roles and relationships using 4 concepts: mission, methods, stakeholders, and impact on the left, or the why, how, who, and goals. In the 19th century, starting to the left, slave plantation owners and OBGYNs aspiring to increase productive and reproductive labor by forced sex, birthing, breeding, partnering, parenting, and family planning onto Black women, men, girls, boys, and gender expansive people. The impact led to an increase in the number of slave births and a sustainable and viable slave economy. Next, the 20th century, OBGYNs again. Government officials at the local, state, and federal level, law enforcement officers, family and reproductive health providers aim to reduce or eliminate the socioeconomic burden of the browning of the U.S. through coerced contraception, forced sterilizations, controlled births, and forced destabilization and separation of families, households, and communities. The desired impact was to decrease births of the unfit or others, aka Black and brown babies. Again, let's keep going. By the 21st century, these same stakeholders and some more hold more power and increased numbers in hospitals, health systems, health plans, physician and nurse leaders and educators, quality improvement, and OBGYNs and other sexual and reproductive health providers. They were united in the systematic medicalization, professionalization, racialization, and regulation of birth work, and birth workers, with the concomitant erasure and or exclusion of a diverse, inclusive, and thriving Black and brown workforce and birthing communities. The methods, again, included forced interventions, forced inductions, cesarean births, postpartum sterilizations, and long-acting reversible contraceptives with the goal of separate but equal care outcomes and experiences. You made it through. Content warning. So during session 2, I shared a bar graph illustrating racial inequities that determine who lives and dies during pregnancy. This session, I just want to read the specific language here, describing the statistics, and continue to challenge you to reframe the way we talk about this manufactured maternal health crisis in the following way, in bright red. I don't lead with Black mothers are more likely to, because Black mothers birthing people are not coming into hospitals wanting these things. So what if we were to reframe and say white, Hispanic, and Asian mothers and birthing people are 3, 4, and 5 times more likely to live throughout pregnancy and childbirth? And consider that for every maternal death, at least 70 more women almost die. That means more than 3,500 Black mothers and birthing people are almost dying every year. They bear witness to nearly dying. So why are we not centering the living in our work while also honoring our mothers prematurely taken from us? Black mothers and birthing people who almost die are living testimonies, witnesses of all that is horrific with the U.S. maternal health system. So, with little to no support from my physician peers and leaders, I intentionally approach obstetric quality improvement and implementation from a Black feminist lens. This is the formal definition of Black feminism, and to turn it into a praxis requires leadership, political will, knowledge construction, replication, and translation as much as possible from women of color in general or Black women in particular. So I integrate Black feminist praxis throughout my work to deliberately avoid willful reproduction of anti-Black racism, misogynoir, epistemic redlining, epistemic injustice, testimonial justice, and hermeneutical justice, all that I shared during session 1. My ethical, theoretical, and methodological approaches are grounded in a Black feminist belief and behavioral ecosystem that acknowledges and amplifies these things. Black women activate their own power to define their worth and value. You will never hear me say I empower anyone. We activate people's existing power. Black women confront and dismantle systems and structures of intersectional oppression. Black women intertwine intellectual thought and political activism. Black women honor their innate and inherited energy and skills to resist and transform daily discrimination. Application of a Black feminist praxis permits us to then embrace and celebrate and protect the breadth, depth, and heights of the humanity of all women, girls, and gender expansive people as we mitigate acts of obstetric violence and obstetric racism. The next theory. We can no longer deny the historical and contemporary existence of reproductive and perinatal apartheid in the U.S. health system. So in 2018, 8 years ago, I described the meaning, manifestation, and mechanisms on the left, right, of action of this type of apartheid as an adaptation of ethicist and author and brilliant scholar Harry Washington's medical apartheid. Reproductive and perinatal apartheid describes a system of racial and ethnic separation, almost like cleansing, but it kind of is. Rooted in a hierarchy of humanity based on skin color and genitalia, plus other things, resulting in the pursuit, provision, and proliferation of safe, respectful, dignified, responsive, high quality reproductive and perinatal care and experiences during pregnancy, labor, and childbirth and postpartum for one or two dominant groups in the US society, essentially white and Asian women, based on data. In the US, reproductive and perinatal apartheid, it manifests in differential ways, right? Differential access to life, liberty, and the pursuit of happiness, as described using these exemplars on the slide. This list is not exhaustive. Reproductive and perinatal apartheid are operationalized through mechanisms of action that continuously and simultaneously privilege one universal notion or truth or example of womanhood, humanity, femininity, sexuality, reproduction, birth, and motherhood, parenthood, that denies, constrain, undermine the self-determination, expression, and development of a less dominant group in the absence of reproductive safety, agency, and dignity among structurally excluded, marginalized, or minoritized groups. So, Black feminist praxis shapes our assumptions and truths. We hold these truths to be self-evident. We believe, trust, value, and adore Black women, girls, and gender-expansive people. Black women, girls, and gender-expansive people are worthy, period. Not, that's it. We are worthy. We protect, prioritize, cite, and amplify the voices, intellectual thoughts, lived experiences, and political activism of Black women, girls, and gender-expansive people. We affirm, activate, and amplify the power and potential, not pathology, of Black women, girls, and gender-expansive people and our given and chosen kin. We're going to keep going through these theories so you can see how they're all connected. And these are my favorite ones I'm sharing with you today. So, sacred birth. Black feminist praxis informs and shapes our vision for a sacred birth. Prior to my research, I needed a North Star to illuminate my path. Thus, I was inspired by the book Birthing Black Women Birthing Justice, because I'd never even heard the word sacred or sacred and birth together as a vision, as an experience, an expectation, or expression, or even as a quality metric during my time trained as a medical student or as an OBGYN resident. So, thus, I developed another concept called sacred birth, given the limitations in the existing quality and patient safety paradigm in obstetric care. So, read along with me. Sacred birth is a radical attitude towards human births, specifically Blackness, Black bodies, and Black births, that regards all birth activities as fundamentally normal, healthy, spiritual, familial, magical, transformative, even erotic, communal, emancipatory, and power activating. Sacred birth encourages diverse and inclusive birth pleasure, practices, care, spaces, options, partners, communities, and experiences. The sacred birth movement advocates for safer, respectful, dignified, high quality, participatory birth care, conditions, experiences, and outcomes, and a restoration of Black midwifery care and Black doula support models as part of its campaign. And I need to add Black lactation educators and Black mental health, behavioral health specialists. So my cosmos of North Stars continues to expand. I include the brilliance of the late, great Leith Mullins, a prolific anthropologist, mentor, teacher, and pioneer in Black feminist studies, whose intersectional framework of oppression, resistance, and resilience, the Sojourner Syndrome, as well as her research methodology and impact in shaping how we think about the social context of reproduction, grounds and fuels my scholarship and activism. So the Sojourner Syndrome, an interpretive framework for understanding. This comes from the first one was from her work and looking at the experiences of birthing in Harlem. This work has also been applied in poor Black women's HIV risk. But the point that I want to stand out for you that it is an interpretive framework, right? It's how we can contextualize pregnancy and childbirth experiences and outcomes among Black mothers and birthing people. And on the right, it illuminates how structurally marginalized Black women and people both resist, disrupt, and or transform these intersecting obstacles into acts of resilience and resistance. It's not just the oppression, it's also how we respond and resist and recover and reclaim. So it shifts our perspectives on health and illness by inviting us to understand race, class, and gender as these relational concepts, social constructs, and not as the innate attributes of people of color, the dispossessed, or women. So again, Sojourner Syndrome is how I'm able to disrupt biological determinism by reimagining, right, our communities in a different way so that we can think about different ways of redistributing power, resources, privilege, power, advantage, and disadvantage. On to another theory, first coined by Professor Moya Bailey in 2008, 18 years ago, while writing her dissertation. Misogynoir originates from slavery with modern day manifestations and implications and describes the uniquely co-constituted racialized and sexist vitriol and violence imposed on Black women as a consequence of simultaneous and interlocking oppression at the intersection of anti-Black racial and anti-Black gendered marginalization. Misogynoir allows us to better understand, recognize, interpret, and hopefully address the ways that anti-Black and misogynistic ways show up not only in digital spaces, but so-called healing or healthcare spaces. Consider the language, the words that we use in our interactions, our communications, our decision-making, and documentation and dissemination of healthcare information about Black women and gender expansive people in the patient handoffs, the patient sign-outs, and the electronic or paper health records. Words that are on the screen: unfit, lazy, irresponsible, non-compliant, difficult, hostile, unreliable. Next, we have obstetric racism by Dr. Donnie Davis, first defined in 2018, 8 years ago. Obstetric racism describes the beliefs and practices used by hospital personnel against the reproducing Black body that sit at the intersection of obstetric violence and medical racism. Obstetric violence describes situations where medical professionals and staff exert reproductive dominance over their clients. Medical racism occurs when the race of a patient influences the treatment or diagnostic decision and the broader context of medical provision and involves the racialization of every aspect of every cell and organ and tissue in the body, the Black body. So obstetric racism describes beliefs, practices, protocols, all the P's, procedures, and policies that are based on racial hierarchies of human value that track along histories of anti-Black racism and eugenics. Obstetric racism manifests in specific identifiable ways as diagnostic lapses, neglect, dismissiveness, or disrespect, intentionally causing pain, coercion, ceremonies of degradation, and medical abuse. Dr. Davis describes three responses to obstetric racism: refusal, again, resistance, and racial reconnaissance. Back to that Black woman pediatrician story of how she brought together her Black OBGYN friends to protect her, to shift the power and shape safety for her in her birth experience. Language and behavioral information, right, informs our interactions, our communication, our counseling, our decision making, right? All the ways that these forms of violence show up, we can utilize these theories to better understand, interpret, and hopefully better respond. Again, those 6 dimensions of obstetric racism are found on the slide with the definition. You'll have access to these slides so you too can begin to better see how these things manifest and hopefully be better at mitigating them. So in 2019, my team and I translated Dr. Davis's work into the first and only patient-identified obstetric quality framework titled Sacred Birth, in partnership with 2 California-based Black women-led community-based organizations, the African American Breastfeeding Cultural Outreach Task Force, or BCOT, in Oakland, and Black Women for Wellness in Los Angeles, along with 36 Black mothers from both communities who birthed in a hospital setting between 2017 and 2019. We co-developed and implemented a methodology for conducting participatory focus groups and consensus dialogue that led to my current book, Sacred Birth: Mobilizing a New Quality Paradigm in Obstetric Care. Using a Black feminist hermeneutic phenomenology and public health critical race methodology, I translated the stories of 36 Black mothers into the first Black patient-driven obstetric quality framework, Sacred Birth, with a C and a K, operationalizing Dr. Donna Davis's obstetrical racism into 7 novel quality care domains, whose meanings and manifestations and measures were developed for by and with Black mothers and Black community leaders in 2019. Critics of my work repeatedly argue that the use of obstetric racism is too harsh, negative, and off-putting. This slide highlights a quote from a Black mother in Los Angeles in 2019. When asked how she felt about the quality of care and support provided to her by hospital clinicians and staff, she shared, "You push out the baby and you go back on the fields and you keep picking the cotton." Thus, obstetric racism serves as a more accurate and precise phenomenon and analytic by which to name, measure, monitor, and mitigate harm in the form of quality, safety, and human rights violations as defined through Black patient experience and community wisdom. Again, prior to my work, there was no validated measure of obstetric racism. And for the sake of time, today we have one. Since 2022, we partner with over 1,100 Black women and people as patient, community, and content experts, with only 6 non-Black women content experts across 348 hospitals and 34 states, including DC, right? To how could we reimagine evaluating hospital performance when the experience becomes the measure, right, of harm. And that's essentially what we did. And with those 6 or 7 theorized domains, 4 of them kind of were included into one called humanity, the other one racism, the third being kinship. So we're now able to empirically measure obstetric racism across these 3 independent and validated instruments. So when pursuing and supporting birth, independent of setting, provider type, pregnancy intention, or patient family characteristics, as trauma-informed, pleasure-focused, power-activating, spiritual, inclusive, radical, liberating, and participatory, we cannot deny that obstetrical racism is a threat to sacred birth. So during the first session, I shared Dr. Kamara Jones's 2014 definition of health, and as another North Star in my cosmos, grounding clinical ethics and health equity shows us how we continue to miss these opportunities to advance new ethics in obstetric quality and patient safety. Our current ethical approaches are sometimes ahistorical, atheoretical, all the things listed on the slide, exclusive, driven, and beneficial to gatekeepers only, making us all extremely comfortable, complicit, and complacent with more than 80% preventable, predictable, and disparate deaths and devastation. I think there was a question asked from how could we do this in QI? Well, I also developed that as well. The Virtual Quality Improvement Prioritization of Affected Communities, the VQPAC protocol, developed in 2020 with 15 Black women community-based organizations listed on the screen, and 15 Black women from those organizations, 24 Black women from the 15 organizations on the screen worked with me and brought their lived experience from their various ways that they resist and activate resilience in their communities to essentially name. They named 75 mitigations across these domains of obstetric racism, across these domains of sacred birth, and eventually the Primo B scale suite. And from those 74 generated ideas, they prioritized 44. And then on the screen are the top 2 mitigations that they would recommend quality improvement hospitals consider. And none of these improvement initiatives have anything to do with pathology. It's all about the ways in which we are honoring people's humanity. and to make sure we get through all of our objectives, and then we'll go to the brief narrative analysis. I just wanted to make sure that you see that I have provided examples of multi-level solutions across um, each level of structural, institutional, disciplinary level of ways that we can shift power and shape safety. So, on the structural level, one way is what if we endorse obstetric racism as an adverse event, or more specifically, a never event by dominant quality, safety, accreditation insurance companies? At the institutional level, what if we were to implement what we're going to do again today in the remaining minutes, the Black Birth Analytic Method, or the PHI Approach plus Black feminist perspectives during medical education, peer review, and maternal mortality and morbidity review to improve understanding, describing, monitoring, and modifying how hospital systems, teams, clinicians, and support staff contribute to quality and safety violation. And at the disciplinary level, consider the integration of obstetric racism, the sacred birth framework, and the Primo B scale suite as a core competency evaluation tool as approved and authorized by your residency training, by your department. And more of these examples are listed in my book, In Sacred Birth, in Chapter 8. So you made it. You got through this. So congratulations for our popcorn course on Black feminist perspectives. You were introduced to at least 6 theories. The ones that we're going to focus on in this narrative are on the screen. So again, get your devices ready. We're going to go through the same Black birth as before. And is that birth safe or unsafe when we apply the PHI approach and Black feminist perspectives? So if you can remember, the PHI approach is not protected health information or personal history. It is P for patient, expectation, experience, or expression, or their action. What's the hospital response to the patient? And what's the impact of the hospital's response on the patient, their experience, and their safety? And then we'll add these Black feminist theories with their domains that best contextualizes or explains the PHI interpretation. So again, back to that narrative from session 1. Now, I'm gonna not read the whole thing because of time, but we're gonna focus on the first 2 phrases, and I at least want to get you to one phrase that you can do yourself. So this I'm just gonna say wasn't, oh no, sorry. This was indeed an unsafe birth. But I want to share that for folks who weren't with us the last time. This is a Black woman, lawyer, married to a Black man engineer. They have a household income of over $500,000. These are all the positive things that you tell our communities to aspire to that would make us healthy, that would keep us right, that will allow us to experience life, liberty, and the pursuit of happiness. Well, none of these things protected her, right? So in thinking about emotional safety versus emotional harm, we'll start with the first sentence like we did the last time. So the biggest issue I had with my labor and delivery experience is the fact that I developed a birthing plan in writing prior to delivery that was in my chart regarding pain control, yet it was not honored. This is an experience that a Black mother left at the end of my survey for validating the Primo B scale. All the question I asked was a statement. Thank you for taking part in the study. Here's the question. Is there something else you want me to know? And mothers just shared their stories. So in that first sentence of this Black birth narrative, we're applying the PHI approach. What's the patient action? She developed a birth plan. She had an expectation for pain control. What's the hospital response? They violated her birth plan. What is the impact? There was a mismatch between the patient expectation and patient experience. The birth plan and pain control feels like big patient priorities. There was a dismissal of her birth plan and a violation of patient autonomy, and the violation of the patient's feelings of security, connection, comfort, support, acceptance, dignity, and protection. So now, if we were to name the most relevant theory and domain to best contextualize or explain what's going on, I will share with you what I decided to use. Black feminist praxis. Who knew that a birth plan was a manifestation of a Black feminist praxis? Why? Well, with a birth plan, a Black woman activated her own power to define her worth and value. A Black woman confronted and dismantled systems and structures of of intersexual oppression. She anticipated harm. So her birth plan allowed her to, she thought, confront and dismantle those harms. This birth plan allowed her to intertwine her intellectual thoughts, and birth plans are acts of political activism. And she was able to honor her innate and inherited energy and skills to resist and hopefully transform daily discrimination. And just so you know, if you do have a birth plan and you are supporting someone else's Black birth plan, you are essentially upholding a Black feminist praxis, even if you're not a Black feminist or a Black person. Other theories I thought about, obstetric racism, right? In the specific domain, I thought about neglect, dismissiveness, and disrespect. When medical professionals ignore or dismiss a person's expressed need for reproductive health or care and or treats them with disdain. I thought about coercion. When medical professionals perform a procedure without consent and or intimidate patients to make decisions. This next sentence, I know it's 8 minutes before the hour. Let me do this next one, and we're going to quickly do one together for those who can at least stay on. The second sentence, I expressed my need and want for an epidural to anyone who would listen, that cared for me during my time at the hospital, yet somehow I was forced to deliver naturally without any pain medication. Apply the PHI method. The patient action communicated the need and desire for an epidural. The patient had an expectation to be seen, heard, valued, cared for, held, protected, and to be offered pain control with an epidural. What's the H? The hospital response, a forced, unmedicated, painful vaginal birth. And what is the mismatch? What is the impact of the hospital response on the patient, their safety and their experience? A mismatch between patient expectation and patient experience. Getting an epidural feels like the number one patient priority. A dismissal of pain severity, a violation of human rights for pain control. Again, a violation of her feelings of belonging, psychological safety, and connection. Well, what Black feminist theory do I think about? I think about obstetric racism. I think about two, right, of those dimensions that I already talked about, neglect, dismissiveness, or disrespect. Again, the rationale, their meanings are on the screen. I'm also adding intentionally causing pain. When medical professionals fail to appropriately manage pain, which may be rooted in racialized beliefs about pain immunity, and as well as the absence of empathy for Black people's physical or emotional suffering, leading to a lack of internal motivation to alleviate or reduce Black suffering. So, pull out your devices. Let's do this together quickly. Based upon what you've gleaned today and the examples I provide to you in the last session, let's apply the PHI approach and the Black feminist perspective to this phrase from this Black narrative. This was not because I had a quick labor either. I got to the hospital at 7 p.m. They started my induction at about 10 p.m. and I did not deliver until 6:06 a.m. So they had ample amount of time to fulfill my need for an epidural. Describe the patient expectation, experience, expression, or action. It's not a trick question. Based solely off of this phrase, what is the patient's expectation? And please, just no one's going to know it's you. It's anonymous. So if I have a courageous and daring first responder, thank you. Adequate pain control, right? That's her expectation. What's her experience? Feeling abandoned. She expected an epidural. She expected to be seen for the epidural, right? She was expecting help and respect, pain management, right? That's what she expected. Let's keep going, but keep answering. What was the hospital's response to the patient? That's the H. It is not a trick question. First responders, who's going to be courageous enough to thank you? Nothing. Absolutely nothing. What else would they? What are other hospital responses? Delayed, inaction, correct, dismissive, not caring, exactly. Hospital did not organize its systems to meet her request, ignored her. She didn't get epidural, did not fulfill her wish, right? Keep pouring it in. Nothing, ignored, dismissed, bias, neglect. Absolutely. What's the I? Describe the impact of the hospital response on the patient. Again, not a trick question. Trauma. Thank you, first responder. What else? What are the other impacts? Pain. Exactly. Negative. Distrust. Thank you, responders. What else? What are other impacts? Neglectful, physical pain, disenfranchisement, unnecessary suffering and isolation, abandonment. Thank you. Now, here we go for today. Out of all of the theories, first responders, be courageous, be creative, be daring. And even if you don't know and would like to know, I will accept that as well. What Black feminist theory comes to mind when just looking at this sentence? What Black feminist theory comes to mind? Do you need a little help? Reproductive apartheid, especially if we think about all the data that's out there, which I talk about in my book around pain. This is exactly reproductive apartheid. Obstetric racism, yes. The Sojourner syndrome, right. Structural ways around how we approach, view, see, take care of Black reproducing bodies and Black births. What are other Black feminist theories that are either being affirmed or being violated? Reproductive apartheid, thank you. What are other ones? Right. So remember, I talked about a birth plan was a manifestation of all four tenets of Black feminist praxis. This is a violation of Black feminist praxis. Yes, this is misogynoir. Right. Yes, this was not honored as a sacred birth. Thank you. You did it. I will leave the slides for you all to have. I know there's 3 minutes left, but I just want to show you how in 2 weeks, 2 hours tops, you are doing more than what this country is actually doing. The slides are going to be there. The rest of the sentences are there for you to practice. Um, and you can see my response for every phrase. I'm just trying to get to the end, but I know there's 3 minutes left. I just want to say thank you, thank you, thank you. You made it to the end in a popcorn style, but I just wanted to show you how in just 60 minutes you were able to analyze a birth narrative using this PHI approach, and you applied a Black feminist theory without necessarily being a Black feminist. And that was the whole point of this work, is that don't allow these words or these languages to intimidate you. Just know that there are more accurate and precise ways to better understand the oppression, but also the resistance and resilience, even in quality improvement and patient safety. So thank you.
Thank you so much, Dr. Scott. It's such a pleasure to have you here with us today. And thanks everybody for your great participation
Yeah.
in applying these frameworks. I really appreciate seeing you all here and doing this work together.
Thank you, thank you. I know there's 2 minutes left, but I will follow Gina, Jill, and Carrie's lead. I'm here if anyone has a question, but I just so appreciate. So just so you know, you're the second group in the country to have this training. And so I just thank you so much for participating in the way that you have shown up today and last week.